Se empieza a grabar.
Bienvenidos a esta nueva versión del Webinario Internacional de Educación Continua en Vía Aérea, organizado por el Programa de Anestesiología y Reanimación de la Universidad Diego Portales. El Programa de Anestesiología y Reanimación de la Universidad Diego Portales es liderado por el doctor Ricardo Latrop Allende, quien es su director, y el programa tiene como objeto lograr formar un especialista capaz de ejercer la anestesiología en forma integral, entregando al paciente una atención acorde con la evolución de la especialidad, adaptándose a los cambios epidemiológicos y al desarrollo de la tecnología. Este programa está acreditado por la Comisión Nacional de Acreditación CNA de Chile y eso nos eleva a un nivel mayor en cuanto a nuestro quehacer y nos insta a seguir perfeccionando. Nuestras autoridades están encabezadas por la doctora Patricia Muñoz Casas del Valle, que es nuestra decana, y por el director de la Escuela de Posgrado, el doctor Antonio Eblen Sahur. Nuestro webinario cuenta con el soporte académico de la Sociedad Europea de Vía Aérea, la EAMS, y también por la organización FIVIVA, que es la Formación Internacional en Docencia e Investigación en Vía Aérea, fundamentalmente en España. Los quiero invitar muy cordialmente, muy entusiastamente a hacerse miembros de la EAMS. Tiene varios beneficios ser miembro de la EAMS, con la suscripción online a la revista Trends in Anesthesia and Critical Care, órgano de la EAMS donde publican los más grandes investigadores del mundo. Que hay acceso preferencial a contar con speakers de renombre mundial si organizan un evento o curso. Tiene una iniciativa de investigación colaborativa en vía aérea coordinada por la EAMS. También hay una red de residentes. Hay posibilidad de formar un council
No.
en países y representar a sus países ante la EAMS. Hay descuentos en inscripción a eventos científicos y también hay recepción del artículo del mes, que ustedes mensualmente pueden obtener un artículo seleccionado por grandes expertos para leerlo durante ese mes y estar al día acerca de los principales temas en vía aérea. Las membresías tienen un costo, por supuesto, que está reducido para nuestros países de Latinoamérica y ustedes pueden acceder a la página web para este efecto activando el código QR que tienen en sus pantallas. Nos complace tener un servicio estupendo de traducciones simultáneas, tanto al portugués, al inglés y al español. Hoy día tenemos un expositor de habla inglesa, por lo tanto los instamos a que activen sus canales de español y portugués de acuerdo a sus idiomas para que puedan obtener la mayor calidad de la transmisión de la información que van a obtener hoy día. Les damos las gracias a la empresa Traducciones Remotas por este extraordinario servicio que nos prestan. Los invitamos a todos a participar activamente en este webinario. Este webinario es totalmente interactivo. Ustedes pueden enviarnos sus comentarios, sus preguntas a través del chat o también levantando la mano en el botón de reacciones que tienen en la parte de abajo de sus pantallas. Pueden levantar la mano y formular su comentario o su pregunta directamente al expositor o a alguien más. Y nos encanta, por favor, díganos desde dónde nos están viendo, desde qué país o de qué lugar se están conectando para nosotros saber nuestro alcance y saludarlos a todos independientemente del lugar donde estén. Aquí tienen ustedes esta constelación de grandes expertos mundiales en temas diferentes de vía aérea. Ya hemos tenido a varios. Esta es la séptima edición del año 2024 y todavía nos quedan hasta diciembre, en que la última expositora va a ser la doctora Elno Sullivan de Irlanda. Aquí tienen ustedes el calendario con las diferentes fechas, los diferentes títulos de cada una de los webinarios que se han realizado. Hoy día 27 de julio tenemos al doctor Hofmeyr de Sudáfrica, ya se los voy a presentar. y también les voy a anunciar el próximo webinario del día 31 de agosto. Quiero invitarlos muy especialmente a participar en este extraordinario estudio, que es el estudio AWARE, que es el estudio de una encuesta internacional sobre intubación traqueal vigil. Ustedes al acceder a al sitio web donde está el formulario de la encuesta, activando el código QR que tienen en sus pantallas o el enlace que tienen abajo, pueden acceder a esta encuesta que está en español. Así que no hay ninguna dificultad con el idioma para poder participar en este estudio internacional liderado por la EAMS. Quiero a continuación presentarles al doctor Hofmeyr. Él es un anestesiólogo sudafricano, orgullosamente sudafricano, nacido y criado en la ciudad del Cabo, Sudáfrica. Sus áreas profesionales de interés se centran en el cuidado crítico y agudo, el trauma, la anestesia, la medicina de emergencia, en medicina aeromédica, en medicina del desierto y de expedición. Él es un gran excursionista y ha trabajado extensamente como médico de expediciones, incluyendo su servicio como líder de expedición invernal y médico para la expedición antártica de Sudáfrica. Es cofundador y director médico de Wild Medics, la primera compañía sudafricana que ofrece entrenamiento acreditado en medicina del desierto. Después de cambiar su foco predominante a la anestesiología y medicina perioperatoria, encabezó el desarrollo del primer fellowship africano en anestesia de la vía aérea y torácica, y actualmente es profesor y líder en vía aérea para el Departamento de Anestesia y Medicina Perioperatoria en la Universidad de Ciudad del Cabo. Los intereses clínicos y de investigación de Ross incluyen todas las facetas del manejo de la vía aérea, anestesia cardiotorácica, cuidados aeromédicos y prehospitalarios, medicina remota y de expedición, investigación de punto de atención, fisiología de la termorregulación y extrema. Ross ha asegurado financiamiento de subvenciones educativas y de investigación de la Sociedad Sudafricana de Anestesiólogos, Sociedad Médica del Desierto, de la Universidad del Cabo y de la industria médica, contando con más de 90 publicaciones revisadas por pares. Ross es un entusiasta director de cursos, instructor, expositor internacional dinámico y entusiasta de la educación libre y de acceso abierto, que ha sido reconocido internacionalmente por sus esfuerzos educacionales con premios de la EAMS, la International Airway Management Society y las sociedades médicas del desierto. Por estas razones, nos honra con su presencia en nuestro webinario una persona que de manera incansable dedica su tiempo e interés a múltiples áreas de la medicina. En esta oportunidad en que el doctor Hofmeyr nos acompaña en nuestro webinario, nos hablará de la experiencia que él y su equipo de trabajo han logrado en la resolución de las estenosis traqueales. Muchas gracias, doctor Hofmeyr, por acompañarnos y brindarnos su experiencia en este día. Te cedo la palabra, dejo de compartir. No sé si quieres mencionar algo, Ross.
Thank you very much, Ricardo, and it is truly my honor and privilege to be able to address you and your team today and all of your listeners. I feel very strongly our connection across the waters here in the Southern Hemisphere, and I really hope that we can learn things with each other and from each other. I haven't had as many opportunities to visit Chile and South America as I would wish, although I've done some beautiful hiking and some travel in Punta Arenas and in Torres del Paine and the area of Patagonia. So my thoughts are very much there. I gather it's quite a cold morning in Chile, and it looks like there's been very nice snowfall there. We have just had a storm sweep through here in Cape Town, and I'm grateful that you showed that picture of UCT on the slopes of Devil's Peak, which is just outside my window. In the broad sunshine, because it would be a better advert as opposed to the clouds that are here today. And so I've been invited very kindly by Ricardo to speak on the topic of my choice.
Perdona, Ross, discúlpame si te interrumpa un poco, por favor. Quisiera que mostráramos primero las preguntas que tú mismo has preparado para todos nosotros. ¿Te parece antes de empezar?
Absolutely, yes, 100%. Please continue.
Perfecto. Por favor, Gabriela, ¿nos podrías mostrar la primera pregunta? Esto es para todos. Dice, estas son preguntas enviadas por el doctor Hofmeyr. ¿Qué proporción de las estenosis traqueales en adultos es iatrogénica ocurrida después de una intubación traqueal o traqueostomía? ¿Un 0,19%, un 9%, un 19% o un 90%? ¿Qué les parece? ¿Cuál es la principal causa de estenosis traqueal iatrogénica después de una intubación traqueal o traqueostomía? Aquí las opiniones están algo divididas. Estas preguntas son a modo de introducción antes de la charla para poder conocer vuestras opiniones. Ahí tenemos los resultados, Ross. Hay un empate entre 9% y 90%, y después también en menor proporción están las letras C, 19% y 0,19%. No sé si tienes algún comentario, Ross.
So I'm glad to see such a spread of the answers, and I don't want to give it away before I speak further. I think we'll probably identify that tracheal stenosis is a very challenging problem as I'm continuing with the talk, and I suspect quite a lot of people are going to be surprised by how often that problem is as a result of our medical interventions.
Correcto. Vamos a la segunda pregunta, Gabrielita. La segunda pregunta es, ¿la estenosis, esto es verdadero o falso? ¿La estenosis traqueal no diagnosticada debería ser considerada como un diagnóstico potencial cuando la intubación traqueal falla debido a imposibilidad de avanzar el tubo? Es decir, que cuando uno no puede avanzar el tubo dentro de la tráquea, una causa puede ser la estenosis traqueal que no está diagnosticada. Y este diagnóstico debería ser considerado cuando nos ocurre eso.
Creo que no está.
Oh, vale. Mira, sí.
Perfecto, ahí está el resultado, Ross. 100% todos consideran que es un diagnóstico que debe ser considerado.
I think, Ricardo, this is showing that people have some experience because certainly it shows people have been caught out or have heard of people being caught out before. So I'm very, very happy to see this result, and this gives me a great amount of confidence.
Fantástico. Vamos a la tercera. Ahí son 3 antes de la charla. La tercera, Gabrielita, no sé si puedes mostrarla.
Solo puedo ver los resultados.
Pero en la tercera, ¿no puedes mostrarla, la tercera pregunta?
No, no se puede.
Ah, bueno, no importa. Ross, hay problemas con la tercera pregunta, entonces comenzamos con tu conferencia en este momento, si eres tan amable.
No problem. Okay, let's dive in. So today I'm going to be speaking about work which is very close to my heart, and that is discussing some of the approaches and the strategies that we have made for managing tracheal and tracheobronchial stenosis. And I say that this is close to my heart because, as you've heard, I'm very enthusiastic about airway management and also thoracic anesthesia, and became involved some years ago in doing a lot of ENT anesthesia as well, and became involved with managing these patients with tracheal stenosis. And I recall my very dear colleague and close friend, Professor Darlene Libber, who is one of our ENT leads here in Cape Town. She said to me, "I'm going to warn you, if you get involved with this work, these patients are going to become your patients until death, either until they demise or until you die." It's been prophetic words in that we've now been walking for quite a number of years with patients with tracheal stenosis, and seeing these people with this challenging condition has led us to a fair amount of innovation, we believe, and spurred on by helping people with the condition. So, by way of a bit more introduction, I'm coming to you here from Cape Town. That is the beautiful Table Mountain that I'm sure many of you will be familiar with, one of our natural wonders of the world. Today hidden in thick cloud, but this is our lovely city. And on the shoulder of the mountain, close to where I'm sitting now, is our academic hospital of the University of Cape Town. This is called Expositor, and it may be known to some of you as having been the site of the famous first heart transplant performed by Christian Barnard in the 1960s. And that very large building on the left-hand side there is the new main portion of the hospital building. And this is where my offices are and where we do a lot of our work. Now, here in Cape Town and in the rest of South Africa, we really have a significant burden of disease, and really it's a triple burden that we deal with. We have a lot of infectious disease, and particularly infectious diseases, inflammatory lung diseases such as tuberculosis, which can also affect the airway. We also have a very heavy burden of lifestyle disease, smoking, diabetes, and other problems. And then we have, unfortunately, because of our large amount of poverty in the country, we do have a very heavy burden of trauma as well. And these three things together seem to have created a minor endemic of tracheal disease, and particularly of tracheal stenosis. So the challenges that we've experienced over the years managing these patients have been many, and we've tried to create some homegrown strategies for dealing with them that are suitable for our context. And some of those challenges involve the fact that the teams managing these patients are often quite dispersed. They are spread across disciplines. No one can really tell me where the ENT's portion of the trachea ends and the thoracic surgeon's portion begins. And often the skills to deal with the airway are unique to specific practitioners from different disciplines, rather than being well dispersed across across the hospitals. And so little centers of excellence and expertise have sprung up, and often they don't communicate with each other very well, and often patients are referred through unusual referral pathways. And so linking up this care has been quite challenging. And even sometimes we've had to deal historically with people feeling like management of these conditions or these patients is very much their territory, and not wanting other people to be involved. We've also had a struggle from the research perspective and from looking at patient outcomes by the fact that our patient databases are often quite siloed. We don't have widespread electronic medical records here in South Africa. Most patient records, particularly in our state healthcare system, are paper-based. Folders go missing. They're not searchable. It's quite a challenge to get records on these patients. And then, as I'm sure many of you are familiar with, we have limitations on things like our staff, our equipment. The example I give here is that of high-frequency jet ventilation. This is not, to my knowledge, available anywhere in Africa. Even in our setting here in Cape Town, we arguably have the highest level of medical care and the most academic medical center on the continent. So we lack equipment, and I suppose they say that necessity is the mother of invention, and that leads us to generate other strategies. And also we have a limit on our space. And here, actually, the greatest limitation we have is access to our theatre time. That's partially due to limits on staffing, particularly recruiting enough highly trained theatre nursing staffing, but also as we go through periods of austerity, such as we're having right now in our state healthcare system, where funding is a challenge, just getting enough theatre time to operate on these patients who are very much in need is a real challenge. We have to be very, very selective. So some years ago, around about 2017, we came together to try and improve the care that was available to our patients. And around that time at Julio, we formed what we call the tracheal intervention group. So specifically looking at tracheal stenosis, but also managing other problems of the large airways, tracheal trauma, some cancers and other problems. We pulled in the lead clinicians from a number of different disciplines. So myself from anesthesia, as well as one or two colleagues, then from ENT and cardiothoracic surgery, from intensive care, pulmonology, and even some from endocrine surgery. And we tried to find the thought leaders, the enthusiasts in those groups, and the people who would want to collaborate to take things forward. We got that group together on a communication platform, and here we just used WhatsApp because it was the most platform agnostic, despite obviously some concerns around data security and patient information there. And we use that for multidisciplinary discussions, which can then happen in an asynchronous on an ad hoc basis. So anybody from anywhere across the platform can say, hey guys, we've got this patient, can I share some images, can we have a quick discussion, and we can slip this into the right place in our service. And then we also are able, through that, when we have specific patients, we can organize multidisciplinary airway lists where we can bring the disciplines together to operate on these patients. And in particular, we've been doing shared cases on our thoracic and our ENT lists. So this has had a number of strengths for us. It's definitely stimulated research. It's allowed us to be much more flexible and respond much more rapidly to patients when they come into the system. The use of a communication system like WhatsApp has meant it's platform agnostic. It doesn't, it's available to everybody who has a smartphone. And it's also accommodated changes in the team over time. So there are lead clinicians such as myself who've been with the team for a number of years, but obviously we have new registrars and trainees and rotating specialists who come in and out of the team from time to time. And actually, it's had the additional benefit that every few weeks I download the chat records from our group, and that's been a useful source of backup to check up on our research records. There's obviously issues around doing it like this, around patient data protection and confidentiality. We have had some toes stepped on and some slip-ups because we bypassed the normal referral patterns, but we've become better at that over time. And then sometimes there's no record if the decision-making happens in the multidisciplinary group. We sometimes pour it, carrying that over into the patient's notes and making sure that there's a record of the discussion what just happened in the folder. And obviously this is quite a non-standard way of keeping records. But as you can see from this quick post here, this was a patient who came to theatre in the thoracic theatres for a tracheal resection and reconstruction. And as we went to intubate the patient, we found that there was a vocal cord polyp, and immediately one of the ENT team was mobilized, and we were able to do a polypectomy on this patient quickly before we proceeded with the thoracic surgery. So an example of a quick success story there. We've also been gathering data on what we've been doing now since 2017, and a lot of my work currently is delving deeply into the conglomerated cases now. And we capture this into what we call the layer. The layer is the large airway interventional registry. And this uses the REDCap program where we capture all of our patients' clinical data and all of their cases, interventions. We try and do this contemporaneously, but it's very, very difficult in a busy practice environment. We have a standardized data capture form, which we at least try to photograph so it can be uploaded later. But one of the biggest challenges is that this work, as I say, happens across dispersed places. So it's very easy to capture cases that are scheduled in our ENT and thoracic theaters, much harder to capture the cases that present as emergencies and happen in the emergency theaters and overnight and so forth. And so that's one of the research challenges that I'm grappling with now. We have had a preliminary look at our layer data, and I present this to you up front before I start telling you more about how we've been doing things, because I think it gives you a nice feel for the kind of patients, the kind of work that we're seeing. We obviously, during that period, all of us on the call, I'm sure, lived through the COVID era, and we had a major change in our caseload and what we were doing. In fact, my personal work pivoted entirely to managing our COVID resuscitation team and working in our COVID theaters. But interestingly, we have seen a significant uptick of tracheal stenosis cases in COVID survivors, because as you can imagine, many of them had traumatic intubations, many had late tracheostomies, many had a perfect storm for developing tracheal stenosis of hypotension, hypoxia, steroid therapy, inflammatory airway disease, etc. However, in that preliminary 5-year period we've got more than 500 procedures. In fact, we are unveiling more as we go quite rapidly in over 180 patients. And at the current time, the range that I have is between 1 and 28 procedures per patient. And I'll have a brief comment on some of our frequent flyers as to why they've had 28 procedures. We see that there is a preponderance of female gender amongst our tracheal stenosis. Now, idiopathic tracheal stenosis, which obviously occurs without any precipitating cause, is far more female dominant. And so in many places in the developed world, we do see a heavy female preponderance for tracheal stenosis cases. Our data is much closer to an even spread. You can see there 60-40 split between male and female patients. And this really is driven by the fact that the acquired tracheal stenosis in adults, as we alluded to in that first question that came out, is about 90% iatrogenic. So 9 out of 10 patients who have acquired adult tracheal stenosis, it's because of an intubation, a tracheostomy, some kind of procedure. And in our population, because of our very heavy caseload of trauma, trauma is much more common in males, and so that skews our patient demographics with tracheal stenosis to a lot more male patients than one would see in the developed world and certainly in the Northern Hemisphere. If we look at patient ages, you can see a little bit of clustering there in our data around about 20 years of age and nothing really below that, and that's purely because this interventional registry is only at our adult hospital. We have a separate tertiary and quaternary pediatric referral hospital, so we're not gathering that data. But you can see we've got a fairly even spread of patient ages up to around late 50s, early 60s, and then we see that tailing off quite a lot, and that's again a reflection of our younger national demographic and our heavy trauma caseload. We look at the cause at the pathology of the patients in our registry for tracheal stenosis. Obviously, stenosis at some level in all of those patients, and we have shown that at least 12% of patients have had a pulmonary tuberculosis diagnosis at some stage. So TB very prevalent in that population, and that 12% is much higher than our population incidence of tuberculosis. And this then clearly reflects that we are seeing quite a bit of post-tuberculous tracheal stenosis. And this is a common cause, infectious cause in other parts of the world. Particularly, interestingly enough, the Koreans have published quite a lot on post-tuberculous tracheal stenosis. In about 83% of these patients, we have performed at least one episode of tracheal dilatation. So the vast majority of our patients have at least a single dilatation. And again, that reflects the fact that many patients present in extremis. They come into the hospital with severe airway compromise, not in a condition where they can be prepared for a definitive procedure, which for stenosis is obviously a tracheal resection and reconstruction. In fact, in our patient population in the layer, only 9% have a resection and reconstruction. So that is interesting because only about 1 in 10 undergo reconstruction. It's probably much lower than it should be with tracheal resection and reconstruction being the definitive procedure. But we also recognize that in some cases, dilatation can be curative. The cure rate for a tracheal dilatation is about 40% in the international literature. And we are diving quite deep into our numbers now to figure out what it is in our population. The cure rate for a tracheal resection or reconstruction in the best hands is about 80%. So although we are seeing 60% of our patients, most likely after a dilatation, returning with a recurrence of their tracheal stenosis, in fact, still in the best hands, in the best centers in the world, about 20% will have a recurrence after a tracheal resection and reconstruction surgery, which is obviously quite major surgery. We do see that about 1 in 8 patients will have undergone tracheostomy at some point in their care, but this is typically prior to their presentation with tracheal stenosis. In fact, before we started our work, it was a very frequent occurrence that a patient would present in extremis with tracheal stenosis with a threatened airway, and they would have a tracheostomy as a life-saving procedure. And as we have grown with our experience, we've nearly eradicated emergency tracheostomy as a primary care strategy. And I'll tell you a little bit more about that as we proceed. Looking at the level of stenosis, you can see there around about 1 in 6 is at the glottic or immediate infraglottic region, and close to half are in the subglottic and mid-tracheal area. And this is really the area that's most commonly iatrogenic. This is most commonly after intubation or an ICU admission. And if we look at our causes in our registry, we can see there that ventilation in an ICU has been attributed as the cause for the vast majority of cases. And if we look at the reason for patients being admitted into the intensive care unit, trauma really is far and away our most common reason. You can see there traumatic brain injuries, other trauma, and overdoses as a particular cause. Unfortunately, we have quite a high incidence of patients who attempt overdose or attempt suicide using losing my word for a second, organophosphates, and this often requires them to be intubated for airway management in the periphery, and sometimes those referrals take some time. By the time they arrive, they've been intubated with high cuff pressures for a while, and we do seem to see that as a fairly common cause. We also do have some patients, as I alluded to previously, who have had a huge number of procedures. Now, you'd think that after you've tried a few dilatations, then really one begins to, once the patient's out of the emergently threatened airway, you would think that we would be working them up and doing a tracheal resection or reconstruction. Now, obviously, not all patients are suited for resection or reconstruction. The stenosis needs to be in an amenable area. It can't be immediately infraglottic. We struggle in terms of the skills and the support that's available to do complex pericardial reconstruction. So it does ideally need to be, mid-tracheal stenosis, and the patient's body habitus needs to be suitable, and their general condition of health needs to be suitable, and they must obviously not have any kind of active infectious disease. Because we do quite a few dilatations and patients then are out of extremis and cured, we often see them go back to the community and then only return months, if not years later, with a recurrence of their stenosis. But we've had some patients where we've had to do repeated dilatations because they continue to restenose, but they are not surgical candidates. The two major contributors here for us are patients whose airway anatomy or simply their body habitus it just does not allow them to have a tracheal resection and reconstruction. In fact, we have embarked now on a plan for some of our patients to undergo bariatric surgery as an intermediate step to hopefully improving their body habitus to the point where they can have resection and reconstruction. And the other major reason why some patients keep coming back to us and can't have definitive surgery is because of an inflammatory or an infectious cause. We've had some patients with autoimmune disease, as well as patients with recurrent episodes of tuberculosis, and even multi or extreme drug-resistant tuberculosis, which remains a scourge in South Africa and very challenging to treat. So all of these factors together have pushed us towards developing our techniques of endoscopic management. You can imagine that doing a tracheal dilatation is something which frequently requires 30 to 60 minutes total time in the operating theater, from the patient coming in, having a dilatation, and then going back to the recovery room, compared to a tracheal resection or reconstruction, which even in very good hands is a 2 to 4 hour procedure, also necessitating an ICU admission. If we can therefore pull off 3, 4, 5, even 6 tracheal dilatations in the time that it would take us to do a full resection or reconstruction operation. And this has pushed us towards trying to improve our techniques there. Now, if we look globally at the approaches to management of tracheal stenosis, obviously dilatation is the ones we've been speaking of, and this historically has been performed using either solid bougies, so your rubber bougies that you're probably quite familiar with. Can also be done using incrementally increasing sizes of rigid bronchoscopes, so pushing a rigid bronch through and then taking a larger one and repeating the process, and of course using balloons. And although there are some dedicated or custom-made balloons specifically for tracheal stenosis on the market, often this has been performed with a variety of cardiac, vascular, esophageal, and other balloons. Then one can stent tracheal stenosis, and the two major approaches here are uncovered expandable metal stents and then silastic or silicone stents, such as your Montgomery T-tube style. And we are incredibly resistant here to using uncovered metal stents in the trachea, because our experience is that they cause so much tracheal irritation and granulation that you have a recurrence of your tracheal obstruction with this granulation tissue which forms through them, and they then become almost impossible, if not impossible, to remove. And so you find yourself in a situation of having to do recurrent debridements of granulation tissue inside patients' airways if they have been stented. So here really we try and limit it to limited duration of silastic stents, or we only use our uncovered metal stents in patients who've got quite bad tracheomalacia. Cryotherapy and thermal ablation have been used in management of tracheal stenosis. Cryotherapy here in South Africa, or cryoablation being, again, a fairly new technique which we've started using, driven by our pulmonologists. We have had very, very limited experience of its use for tracheal stenosis specifically, but it is described in the literature. Obviously, the recurrence of scar tissue formation being a problem, and similar issues for thermoablation, although we do use a laser resection and photodiode laser resection from time to time. We have a neodymium yttrium on garnet laser that we use, but more for making small incisions to allow us to perform dilatation where we've got very, very concentric and fibrotic tracheal stenosis lesions. And then, of course, the definitive therapy that we've spoken about being resection and reconstruction, my comments around patient selection there being applicable. So we do use dilatation a lot, and as I say, we often use it as a temporizing measure to make sure the patient has a sufficiently patent airway that we can get control of their emergent condition, stabilize them, and plan them for surgery for a resection and reconstruction. The challenges, of course, from an anesthesia perspective, are that these patients frequently have got underlying respiratory disease. There's always a reason why they were intubated in the first place. In our context, often they've got tuberculosis and other lung diseases, and they frequently have got quite bad, poor physiological reserves, especially if they've been sick for some time. They don't tolerate anesthesia, surgery, apnea, or anything else very well. There's obviously the concern that everyone on this call will be familiar with, and that is when you are sharing the airway with the surgeon. The surgeon usually has quite different priorities to you. They want full access to the airway, they want time to work, and they don't want instrumentation in the way. Whereas we want an airway that's secured, we want to be able to ventilate, we want to be able to oxygenate. And so these shared airway goals put us a little bit at odds. There's also the challenge of when, depending on how the surgeon's trying to get access, they frequently have to switch between suspension laryngoscopy or bronchoscopy. And so there's devices going in and out of the patient's airway and we have to manage the airway in between. And then particularly for doing balloon or bougie dilatation, not so much with bronchoscopes, but when you put your dilator in, you then cause occlusion of the airway, you cause a period of apnea. If the patient is not sufficiently deeply anesthetized or does not have neuromuscular blockade on board, they can obviously have a risk of barotrauma if they were to cough against an occluded trachea. And these patients often desaturate quite rapidly. We have the issues of sorry, that's supposed to read hypercarbia. That's a spelling error there during periods of no ventilation. So it really is, from an anesthetic perspective, a big challenge. In the developed world or the first world, an approach to managing these patients and giving really good surgical access is often to use high-frequency jet ventilation. And this is a very good approach, particularly with the dedicated machines. This can give you, sorry, we're a little bit of noise in the back there. This can give you an open airway for the surgeon to work on and actually give good oxygenation and ventilation. But as I say, to my full extent of my knowledge, there's not a single high-frequency jet ventilator available on the African continent. So really, this stimulated a lot of research for us, and we looked around better ways of doing this. And the emergent technology for us really was the idea of being able to do dilatation while not obstructing the airway, which would then allow us to do some form of ventilation, whether it's apneic oxygenation or conventional mechanical ventilation or even manual jet ventilation, which are all available to us. And so this is really where the work has gone over the last number of years, and this is what I've been involved in now for going on about 8 years. So the principle was to shift from this. This is a suspension laryngoscopy picture of, you can just see the vocal cords on each side there with a tracheal stenosis in the subglottic area and a tracheal balloon being inflated to several atmospheres pressure, causing complete obstruction of the airway, to rather develop a non-occlusive balloon, so a device which could be used to inflate and create space for the ventilation to go through there. And this is where we were lucky to be able to collaborate with industry. In fact, a company based originally here in Cape Town, who were developing non-occlusive balloons, and they came up with this design or this concept of a balloon which has got structure which consists of subunits. So each of these subunit balloons then push on each other, and they create a central interballoon space that allows ventilation to pass. And this is available in quite a number of different sizes as the work has continued. The larger balloons having 8 subunits, the smaller ones having 6, and it really is actually quite an impressive piece of engineering. I take my hat off to the biomedical engineers who've designed this, that these tiny little balloons can be inflated up to 10 or 12 atmospheres pressure, and then obviously dilate a stenosis. So the path for us really was that we started with taking this balloon concept and testing it in mannequins just to see how the process would flow. We had to make sure that the balloon had an adequate length that we could pass it right through a rigid bronchoscope. We needed to come up with a way of adapting this so that we could ventilate continuously while doing it. That meant we needed to play with different kinds of stoppers and ways that we could allow the balloon to pass while still sealing the circuit and ventilate. And then through experience with working in the research space, we actually began to think about how can we do this, if not in suspension or rigid bronchoscopy, but can we do this using more conventional airway management, such as through endotracheal tubes, or in fact, even through supraglottic airways. The next step was that we took this into an animal model, and this was some of our early work where we did trial deployments of these balloons in sheep. These sheep were being anesthetized for another study, and we placed endotracheal tubes and then passed the dilatation balloons through the endotracheal tubes into the tracheas and deployed them, and we're able to show that it didn't affect the tidal volumes and didn't meaningfully affect the ventilatory pressures. We were able to maintain oxygenation and good capnography throughout the process. So with the animal work behind us, we were slowly starting to gear up for looking at how we could test this in a prospective trial in humans. when we had a very, very challenging patient present to us. So this was a young lady of 33 years, and she had HIV, she had retroviral disease, and was on antiretroviral therapy, and she developed a progressive worsening of airway stenosis over 2 years. This was affecting quite a lot of her airway from her nasal cavity right down into the bronchi. And initially, the etiology of this was unknown. It was presumed to be some kind of an inflammatory process related to her HIV infection. It was suspected that it might be a strange presentation of tuberculosis or a malignancy, but they struggled to get any kind of diagnosis, including after some biopsies, which didn't show anything conclusive. She went on to actually have acute upper airway compromise and with nasal and laryngeal stenosis. She had an emergency tracheostomy and went on to have a total laryngectomy. And still no very clear diagnosis at that point, but over time, the diagnosis eventually revealed itself to be an IgG4 mediated autoimmune sclerosis. Now, after she had had her laryngectomy and tracheostomy, she then represented to us in extremis. She'd lost a lot of weight. She was barely able to breathe. She was oxygen dependent, and a CT scan revealed that, as you can see here, she had a 4.7 millimeter internal diameter tracheal stenosis, and then bilateral bronchial stenosis, with the right main bronchus coming down to about 3 millimeters, and the left main about 3 millimeters, and the right main about 6 millimeters. And this obviously was an intense management problem. And we put together a multidisciplinary team and said, well, look, what can we do for this lady now? In fact, it was even more emotive because at the time she had a young child. This was really a very big therapeutic dilemma for us because she had stridor at rest despite her tracheostomy in place. Her overall physical condition was very poor. We didn't think that she would cope well with major surgery. And she was, at this stage, oxygen dependent and actually started showing signs of CO2 retention. Now, we determined that doing some kind of bougie dilatation was not feasible because her respiratory compromise was so severe. It was very, very difficult to access the airway because she'd had a total laryngectomy and now had a tracheostomy in situ. We were very worried about the inflammatory nature of her airway and that we might cause airway trauma with bleeding, and this would further compromise her respiration and quite possibly kill her. We looked at doing balloon dilatations through the tracheostomy, but the concern for doing that was, of course, that she wouldn't tolerate apnea very well. So we discussed it with our cardiothoracic teams, and there was a consideration of whether or not we could do tracheal surgery on pulmonary bypass or on ECMO, but particularly at this time, our ECMO service was still quite nascent, and we had very, very strict criteria. And she was deemed not to be suitable for ECMO because there was no clearly reversible component of her pathology. This IgG4 autoimmune sclerosis would potentially respond to disease-modifying drugs, but the time frame for that would be weeks to months rather than days to weeks that would be suitable for ECMO. The cardiothoracic team deemed that a reconstructive procedure was not feasible, and her background illness as well seems a relative barrier to that. We didn't at the time have access to the needed laser, and cryotherapy wasn't at all available, and lung transplantation for patients with retroviral disease at the time was not considered. So the multidisciplinary team's conclusion was that the patient should undergo palliative care. But unbeknownst to most of the NDT was that we had obviously been doing this animal work on the non-occlusive balloon, and we deemed that we may well be able to succeed in this instance if we could continue ventilating this patient with a non-occlusive dilatation. And so we convened an emergency ethics panel, and they in fact gave us ethical approval, with obviously the patient's also consent, to proceed with an attempted balloon dilatation with the new device, despite the fact that it was not yet commercially available, nor had study in humans, but as it was potentially life-saving therapy for the patient. And so we proceeded with this with a great amount of trepidation, recognizing that should we fail, we effectively would have to palliate the patient, there and then. We topicalized this patient's airway. We continued spontaneous ventilation. We used sevoflurane and IV dexmedetomidine, and then we used a pediatric flexible bronchoscope through the tracheostomy, using a bronchoscopy adapter to visually guide the surgeon and into where we could place the balloon. We were able at that juncture to dilate the trachea distal to the tracheostomy tube. There was a stenosis right at the tip of the tracheostomy tube, where obviously it had been irritating the tracheal wall. And then we dilated the right main bronchus. And then in order to get into the left main bronchus, we had to pass a guide wire through our bronchoscope and through the stenosis, and then advance the balloon dilator over the guide wire, which fortunately it has a central lumen which allows a guide wire to pass through it. We're able, with continuous ventilation, to do dilatations of 3 minutes at each site, and immediately her ventilatory parameters improved. And in fact, we were able to wake the patient up, and she was breathing spontaneously, and she survived that first procedure, followed by a second dilatation 2 weeks later. And we then followed her up at 3 months. She had begun responding to her disease-modifying drugs, and at 3 months duration, she didn't require further dilatations. We were able to write this case up. It's published in the Cardiothoracic Journal, and really that was the kickoff for us then driving this work forward in human patients. We went on to do a prospective trial in adult patients presenting with tracheal stenosis. This is also published in the Journal of Cardiothoracic and Vascular Anesthesia. And our initial trial was 20 dilatations. And we showed that in all of those patients, we were able to maintain continuous oxygenation and ventilation while doing the dilatation using conventional mechanical ventilation. And so the way that this technique developed really was that we had started with the way that we traditionally did them, which was using a rigid bronchoscope and keeping the patient breathing spontaneously with inhalational anesthesia, to doing it under suspension laryngoscopy, using a variety of methods of oxygenating the patients, sometimes doing manual jet ventilation, sometimes putting in a small tube or holding a tube with the cuff inflated at the vocal cords to allow us time for apnea. Later, we started infiltrating through the guide wire channel of the balloon, and also jet ventilating through the guide wire channel of the balloon. But we then realized, well, we could do this through an endotracheal tube as well, and using a bronchial blocker adapter, which allows us access for the scope and the balloon and guide wire. And then we realized that if you are struggling to land endotracheal tubes in patients with subglottic stenosis, why not use a device which remains supraglottic? And so we started doing all of these procedures endoscopically through a supraglottic area. And this is an image of the team in the top corner there around a patient. It often does take quite a few hands. So it's usually 1 or 2 anesthetists, one managing the airway and driving the bronchoscope, and one maintaining the anesthesia. And then often a surgeon with an assistant who is watching and placing the balloon under guidance of the bronchoscope. Here on the right-hand side, you can see the equipment that we commonly use. So we've got a flexible bronchoscope passing through the bronchial blocker, multi-port adapter there, going through your supraglottic airway. We've got the guide wire and the balloon passing through the other port. You can connect your mechanical ventilation to the third port. And we've got a variety of different supraglottics and different bronchial blocker adapters, multi-port adapters that we use. And then that device marked I on the right-hand side, there's obviously the pressure insufflator, which is designed to then inflate the balloons. And these balloons have got a working pressure. We typically start at about 6 atmospheres, and many of them go up to 12 atmospheres. So you need a specific device to do that. This work published by myself and Professor Libbo, who I mentioned earlier, in the what they call JLO, jokingly the Journal of Last Opportunity, or the Journal of Laryngology and Otology. And this is really where we published our Cape Town technique of how we do this with conventional ventilation. So to illustrate the technique, we place a supraglottic airway, we connect that multi-port adapter, we start ventilating through the ventilation port. We then put our flexible scope down and we do an inspection of the stenosis, take some measurements, put in our guide wire through the bronchoscope, and then we can put the bronchoscope through the other port while the balloon goes over the guide wire. We position the balloon through the stenosis under bronchoscopic vision, and then perform the dilatation, and obviously then we can remove everything. So there's a couple of images of how it would look actually during a surgical procedure. This is the old-fashioned way that we did it all under rigid bronchoscopy, finding a stenosis. Nowadays, we do this fully endoscopically through the supraglottic airway. You'll see the airway there with the bronchial blocker adapter, the guide wire going through the stenosis, the balloon being advanced with the bronchoscope following it, being positioned in that stenotic segment and then inflated. Sometimes with the larger balloons, you can actually pass the bronchoscope through the balloon and see how it's been placed nicely in the middle of the stenosis like this. And then if you look carefully there, you'll be able to see the misting on the balloon actually showing that we are doing conventional manual or mechanical ventilation. It's usual to get a little bit of mucosal damage or some mild mucosal bleeding, but we've never actually ever had a patient with any kind of significant bleeding that's required any further intervention. So this is now how we've been performing these cases. And obviously, because you can do conventional mechanical ventilation, that does allow you to use inhalational agents. So, historically, we would use often sevoflurane in oxygen. But we've also recognized the fact that because we can secure the airway with a supraglottic and ventilate these patients using conventional ventilation, we're under no obligation to maintain spontaneous ventilation. And in fact, I haven't done a case of a tracheal stenosis with the patient spontaneously breathing for quite a number of years now, except for some very specific cases that I'll tell you about in a moment, where we've actually started performing awake tracheal dilatations. So because you don't need the patient breathing, this means that it's actually very convenient then not to pollute the operating theater environment with volatiles. And so we've shifted almost exclusively now to doing these patients under total intravenous anesthesia. And typically, I do this with propofol and remifentanil. The propofol ablating some of the airway reflexes, which is quite useful and obviously providing anesthesia. And the remifentanil controlling that particular bit of stimulation of deploying the balloon, but also creating conditions of apnea and acting as a very powerful antitussive. So these patients lie still, they don't cough. They also, obviously, when you switch the TCI off, they have a rapid recovery. And this has shifted really our practice from these patients often being inpatients to being able to bring a patient in, do a dilatation under TCI and have them discharged on the same day. So really it's made tracheal dilatation a day case. And now if we look at our numbers, the vast majority are now in our setting being performed under non-occlusive balloon dilatation. From a surgical perspective, you might say, well, how well does it work? And you can see that we uniformly and routinely have an increase in the tracheal dilatation, both using the Cotton-Meyer grading, but also measuring the tracheal, or estimating the internal diameter of the trachea. As I alluded to earlier, we are busy with our 5-year follow-up of our original patients and all patients to date. And if we look at how these original study patients have done, over 60% are still alive. We've lost 15% to early follow-up. There were some patients, unfortunately, who were deceased. One of them was deceased during the index admission to hospital that we actually did the dilatations. She had severe pulmonary tuberculosis with a superimposed ventilator-associated pneumonia and died in our ICU. And 2 others were deceased after being lost to follow-up or due to a documented unrelated cause. So we do seem to be keeping these patients alive for a much longer time, even with dilatation as our standard approach. And so finally, as I mentioned briefly earlier, we've now moved advancing our technique even further. We've gone, well, if we can do these as day case surgeries in patients under anesthesia, we encountered a certain class of patient where, in fact, it was attractive to us to still do this as an awake procedure and still maintain spontaneous ventilation. And that specific class of patient that spurred it on was patients with combined tracheal stenosis and tracheoesophageal fistula, which is a very, very challenging problem, because if you have a tracheoesophageal fistula, then your capabilities for performing ventilation, whether it is manual ventilation, whether it is jet ventilation, actually all go out the window. So when we encountered these problems with patients with stenosis and fistula, we were then encouraged to try and do this awake with them breathing spontaneously. Again, I can't give you any videos showing patients having this procedure, but I can do a step better, and I can show you here two of my ENT colleagues, one of our English colleagues on the right here, in a workshop subjecting himself to a demonstration of awake dilatation. So that's me in the blue shirt and the blue scrubs, and on the right-hand side in the pink shirt and the left-hand side in the green scrubs are two ENT surgeons. And on both instances, we've got a bronchoscope and a non-occlusive balloon down, and we are deploying these balloons and inflating them under topical local anesthesia while these individuals are breathing spontaneously. So if it doesn't give you confidence that the ENT surgeon is happy to have the anesthetist scope them and put a balloon down the trachea, then I don't know what I possibly can do other than to say that we now have a case series of patients in whom we've had this combination of either severe tracheoesophageal fistula or another condition that precludes them from having anesthesia. The gentleman on the left the patient on the left being a rather large patient with a high BMI and also incredibly brittle asthma, and he had nearly not survived a previous anesthetic, and so it was elected to perform an awake dilatation on him as well. So I'll give you this short video narrated by my colleague, Professor Libber, to show you an example of an awake dilatation.
We're presenting this 55-year-old lady with a 3-year history of shortness of breath, and she presented with inspiratory stridor.
So this lady presented to the operating theatre where we were going to do her initial bronchoscopy, and we performed this under general anesthesia using a supraglottic airway to manage her airway, as is our protocol nowadays and that we've described previously. Here we were doing bronchoscopy through the supraglottic with a flexible video scope, and we've identified the tracheal stenosis, and we're then placing a guide wire down through the bronchoscope, which will then go through the stenosis. We do this with continuous ventilation using a multi-port adapter. Once the guide wire is in situ, we are then able to feed a non-occlusive tracheal dilatation balloon over the guide wire. So the bronchoscope's removed, the guide wire remains. We then advance the balloon over the guide wire and follow it with the bronchoscope in order to position it through the stenosis. And we've described this previously in the literature, so this technique and more detail is available there. The patient is under propofol and remifentanil general anesthesia using target-controlled infusions, and we're ventilating them conventionally, usually using a pressure control ventilation mode. So at this point, Darlene is ready to advance the balloon, and we're going to follow that balloon down through the airway, through the multi-port adapter, and then positioned in the ideal position within the stenosis. Here the balloon has been positioned and inflated. You can see the subunit balloons pushing on each other to create a central space, central lumen through which we can continue to ventilate. And in the background, the eagle-eyed will be able to see the capnograph trace and the saturations remaining at 100% while that's going on. Once we've got the balloon out, can have a quick look, and this is the result. And it's interesting to note, particularly with the high stenosis, one sometimes gets some indentation of the vocal cords. And Darlene, you can walk us through the subsequent tracheoscopy.
So this is 4 weeks later in the clinic, and you can see the indentations have completely resolved. The patient's got a normal voice. So with this we do under 2% nebulized lignocaine for about 3 minutes. and we just put a normal ENT fiber scope through, and you can see the stenosis still present but much improved.
So we then decided that this patient may well need a resection reconstruction, but she represented in the interim, and due to theatre list pressures, we decided that we would see if she was comfortable. She was certainly amenable to performing an awake dilatation as a temporizing measure while she waits for a resection. So again, we've now nebulized using a 4% lidocaine solution. We've maintained good oxygenation using high-flow nasal cannulae, and that allows us then to scope. We usually spray some 2% local while we are doing the bronchoscopy and assessing the lesion. And then again, with the bronchoscope through the stenosis, we place a guide wire. We then take the bronchoscope right out. So now we have a guide wire going through one side of the nasal passage down into the trachea. And once that guide wire is then in position, we can take the bronchoscope out, position the bronchoscope through the other side of the nose, and then follow the guide wire down. So here you can see the balloon being advanced over the guide wire, coming through the posterior nasal space, following that guide wire very nicely. One finds if it does sometimes kink a little bit or doesn't want to feed, just pulling back on the guide wire slightly helps guide the balloon down. And we've left some of the little bit of coughing and so forth that happens here because it's quite a good illustration. These patients do need really good topicalization, and if we have a little bit of coughing or something during the procedure, we'll often just top that up. I do this under sedation, so we use dexmedetomidine as our primary sedation agent, and then if the patient is struggling or if we want a bit of extra antitussive effect, we'll add a remifentanil target-controlled infusion. Here the balloon again has been positioned within the stenosis, and then we are trying to do a fairly rapid inflation of the balloon so as not to cause occlusion at this moment. Obviously, once this balloon is inflated, unlike performing dilatations with an occlusive balloon, which has been described elsewhere, the patient's able to continue breathing spontaneously through that central lumen. In fact, we hold this dilatation in this patient. We did 3 sequential dilatations of 3 minutes each with spontaneous breathing. And the patient, as you can see, is quite comfortable here with the balloon inflated to 10 atmospheres in her trachea, just under that bit of sedation and analgesia. You can see in the background, she's continuing to breathe spontaneously, maintaining her saturations at 100%. And if we add capnography using a side stream, then we're able to see that she's actually breathing good tidal volumes and maintaining a normal CO2. I think this is our post-dilatation scope being performed here, just to see that the lesion has dilated nicely. There's a small mucosal tear, which is quite common, and sometimes we'll do a little bit of lavage again with some local. These patients have very, very little post-operative discomfort.
We present.
All right, so I've hopefully given you a nice feel for the work that we've been doing and for some of our approaches. Our mainstay now of managing these patients with severe stenoses, particularly when they're presented in extremis, is to do endoscopic guided dilatations using this non-occlusive balloon that was developed here. And this has proven really to be quite a good bridging option. And in the past, where tracheal stenosis presenting to the operating theatre in extremis would be a lot of drama, and I'd be getting called in, and the head of ENT would be getting called in. Nowadays, it starts to happen at night with my senior registrars who've done this procedure as an elective case many times in the operating theatre, and they'll often do this together with the ENT registrar without calling up a specialist. And this is allowing us to avoid tracheostomy in these patients, which makes them much more amenable to getting tracheal resection and reconstruction down the line if the neck hasn't already been operated on. And although we still are in a position where we are trying to upscale our resection and reconstruction therapies, as I said earlier, I don't believe enough of our patients are getting resections and reconstructions. We're certainly improving the access to care in our resource-constrained setting by using an endoscopic approach such as this. So I think I've been talking for a very long time, and I thank you very kindly for your patience. I'll be very happy to engage and take any questions. Thank you.
Muchas gracias, Ross. Yo creo que ha sido extraordinario el tema que tú nos has traído hoy día. Solo quisiera, de mi parte, antes de ofrecerle la palabra a la audiencia, mencionar un poco la historia de esto. Yo recuerdo, no soy tan antiguo, pero recuerdo que hasta hace no muchos años atrás, este tipo de lesiones, al menos aquí en Chile, eran resueltos con resección traqueal. Se les resecaba sencillamente, quirúrgicamente se cortaba la tráquea y se unían los cabos proximal y distal para poder solucionar esta estenosis traqueal. Y también quiero mencionar que también en Chile tuvimos por muchos décadas una gran epidemia que era por supuesto cíclica como todas las epidemias de tuberculosis. Y que lamentablemente también hoy en día, en los últimos años, ha aumentado su incidencia. Entonces, y bueno, esto fue resuelto, por supuesto, con el mejoramiento de los niveles de vida en Chile y a lo largo de los años, y también con los test diagnósticos y, por supuesto, con el efecto de las vacunas antituberculosis que se convirtieron en una estrategia obligatoria de todo recién nacido, en este país al menos, hasta el día de hoy. Entonces te quería preguntar, Ross, ¿cuál ha sido la historia que tú has visto o que tú has sabido en Sudáfrica acerca de la resolución de las estenosis traqueales y cómo fue cambiando esto a lo largo de los años y han llegado en este momento a tener un enfrentamiento totalmente novedoso para este problema tan importante, tan severo para los pacientes?
So thanks, Ricardo. I think it sounds like we have a lot of common ground between South Africa and Chile on this. In fact, immunization for tuberculosis here in South Africa has always been a policy, but the healthcare system in the country has not been adequate in ensuring that everyone has had access to immunization. And we do have quite a lot of immigration into South Africa from other African countries, which has partially fueled the problem. And because of a lot of poverty, we have people living in shanty towns and living under very poor socioeconomic situations where they're living in very close proximity, and that's contributed a lot to the spread of tuberculosis. So in fact, I think internationally, South Africa, and particularly some regions here near to Cape Town, have had some of the highest incidences of TB in the world. Of course, tracheal resection and reconstruction has been performed here for many years. There are only a few centers, and it's quite specialized surgery, so not a lot of surgeons who are performing resection and reconstruction. So it's not that we don't do it, it's that it's underperformed. And there are not enough centers doing it, and there's not enough access to the surgery. And really that's driven to a larger extent our requirement or our desire to have other strategies which we can use either as a temporizing measure for patients who present with acute severe airway compromise, or as a strategy where we can train people in the more peripheral hospitals and the smaller hospitals who don't have access to thoracic surgery, but could learn to do these endoscopic techniques to then be able to stabilize patients in order to transfer them to the larger centers where we can do the tracheal resection and reconstruction. it's very difficult for us because even in my center where we we have a dedicated cardiothoracic service, we're typically only able to operate on 1 or 2 days a week for thoracic surgery, and a lot of that for us is driven by dealing with the consequences of thoracic trauma, and obviously to a certain extent our thoracic neoplasia, so our lung cancers, and so it saddens me to say that despite this very heavy caseload of patients with stenosis, we're lucky if we're performing a few tracheal resection or reconstruction surgeries a month, whereas we are performing dilatations on a nearly daily basis, certainly a couple a week.
Perfecto, muchas gracias. Yo creo que también, a ver, así, tengo micrófono. También en otros países, en Latinoamérica, la historia es bastante similar. Posiblemente no tienen tanta tuberculosis como una causa importante de esta complicación, pero sí todos hemos tenido la historia y la evolución de los tubos traqueales, que han pasado de ser de tubos de goma con balones de alta presión y bajo volumen, a los balones de PVC con balones de alto volumen y baja presión. Y también, por supuesto, con la cultura de la medición de la presión del inflado de los balones. En ese sentido, quería preguntarte, Ross, ¿cuál crees que hoy día, en el día de hoy, en el siglo XXI, serían las medidas más importantes de nuestro punto de vista, de anestesiólogos, también de intensivistas o de urgenciólogos, para prevenir la formación de las estenosis traqueales? Entonces ya vimos en una de las preguntas que tú formulaste que el 90% de las causas eran de origen iatrogénico. Por lo tanto, da la impresión de que nosotros tenemos un rol importante en la prevención de estas complicaciones.
I agree with you 100%, Ricardo, and there is always going to be a small incidence of stenosis post-intubation, despite our best efforts, because some patients are at higher risk, and some of the factors which predispose patients to developing this condition are those the typical ones we see are hypotension, hypoxia, concurrent inflammatory processes in the trachea. But really, we know from our own work and research that's been done in our center that endotracheal tube cuff pressure monitoring is poorly performed. It's routine for us in the operating theater, and partially because of this work, we've driven it vociferously that every single operating theater where patients are intubated must have its own cuff pressure manometer, and every patient must have the endotracheal tube cuff pressure documented in their anesthesia chart. In our intensive care units, we have bedside manometers, and the cuff pressures are documented on the vital signs charts. So we're meticulous in measuring those. But the work that was done in our center, it was quite interesting. They went and did random measurements of patients in the operating theater, in the intensive care unit, and then in the emergency department, and then they measured the cuff pressures of patients who were being brought into the emergency department. And there was a definite slide in the quality that was available. And typically patients who'd been intubated in an emergency setting, where you can imagine things are often quite fraught. People may, during a resuscitation, forget to check something like a cuff pressure. And certainly patients who'd been intubated in the pre-hospital setting or for transfer to hospital, we sometimes found cuff pressures which were exceeding the 120 centimeters of water, which was the limit of the pressure manometer. So I think the drive here must be one of education and making people recognize how important cuff pressure measurement must be, and how it really should be part of any post-intubation checklist and any critical care checklist, and extending that into the pre-hospital and transfer environment as well.
Fantástico. Mira, antes de preguntarte más cosas, te quiero dar unos saludos que te mandan, por ejemplo, el doctor Oscar Tapia desde Huancavelica, Perú, desde Perú. Te manda saludos el doctor Oscar Tapia. Y también desde Chile, un colega que no se identificó, de iniciales GMC, también desde Chile te están mandando saludos. Con respecto a eso, a lo que tú acabas de mencionar acerca del balón, hay otro aspecto que quizás marque una diferencia entre lo que hacemos en el quirófano y en lo que hacen los intensivistas en las unidades de cuidados intensivos, que es el tamaño del tubo, que en general nos da la impresión de que nosotros usamos tubos más pequeños que los que usan en la unidad de cuidados intensivos. Nuestras intubaciones en general son intubaciones transitorias, por lo tanto, la exposición al riesgo de los pacientes es menor en comparación con la de las UCIs, en que la intubación traqueal son en general más prolongadas y también tienden a usar tubos mayores, de mayor diámetro, para facilitar la aspiración de secreciones bronquiales y el examen endoscópico. No sé qué te parece a ti, si hay alguna influencia acerca de este factor.
Yeah, I am sympathetic towards our colleagues in the intensive care setting wanting to have larger tubes, because obviously that affords much better suctioning of the trachea, access for bronchoscopes and other things like that, and reduces the resistance to flow, improves the quality of ventilation. So I think that using larger tubes in the critical care setting has got benefits, and I think the benefit can always or must always be made to balance against the risk. There's certainly a recognition that tracheal intubation is not a benign procedure, and my own practice, actually, I regard, I always ask the question of whether the surgery that I'm performing or the anesthesia I'm performing can be safely achieved using a supraglottic airway to avoid intubating the trachea at all. And I've become much more liberal in my use of supraglottics. Again, that's not really applicable to the ICU patient, but the literature has shown us that for routine intubation for surgery, the incidence of post-operative permanent vocal changes is about 1%. So about 1 in 100 patients who's intubated for routine surgery will have some kind of vocal cord trauma, which is lasting. And you know, that's 1 in 100 is actually a very high statistic. I think using smaller tubes is a very effective way of avoiding that problem. And I'm often very mindful of asking what is the smallest tube that I can comfortably achieve the procedure with. Obviously, being a thoracic and an ENT anesthetist, I often end up doing procedures with one lung ventilation through double lumen tubes, which have got a very small internal diameter. Also doing a lot of complex ENT surgery through microlaryngostomy tubes. And you will know if you do that kind of work, you can comfortably ventilate a large adult with a 4 or 5 millimeter internal diameter tube. So using a size 8 tube for an adult male, where you could quite comfortably do a procedure with a size 7 tube, that does make a difference to the external diameter. I think the caveat that we have to be aware of is the risk of using tubes that are too small. And I'm not talking about using microlaryngostomy tubes where we have a large volume but a large cuff, so one can get a good seal without having to overinflate the cuff. But the situation in which we place a smaller diameter standard tube into a larger adult and then have to overinflate the cuff in order to generate a seal, and that to me is a risk of tracheal stenosis. I do feel, we said it previously, but cuff pressure manometry and measuring cuff pressures in every single intubated patient should be an absolute standard of care.
Absolutamente de acuerdo contigo, Ross. Creo que nuestra técnica también de intubación traqueal debe ser lo menos traumática posible. Muchas veces uno ve a algunos pacientes que tienen lesiones debido a la intubación y uno pues se pregunta cómo habrá sido intubado este paciente, habrá sido necesario usar un videolaringoscopio en ese enfermo, o si la técnica de la intubación ha sido adecuada de tal manera de evitar producir trauma en la vía aérea. Ya sabemos que los intentos repetidos de intubación generan problemas tanto mecánicos como fisiológicos. Por lo tanto, aquí hay un mensaje también en esta conversación que hemos tenido para los residentes que nos están escuchando, de tal manera de que se tengan una técnica cuidadosa de intubación, de tal manera y de mantención de la intubación, de tal manera de no generar lesiones que puedan llevar alguna consecuencia. Esto nos habla acerca de la conciencia que debemos tener acerca de que manejar la vía aérea tiene riesgos de complicaciones. Y esto que nos ha mostrado el doctor Hofmeyr ha sido un ejemplo extremadamente, digamos, conmovedor, eh, porque las lesiones que ellos están en este momento manejando quizás se pudieron haber evitado con una técnica mejor, a pesar de que hay otras causas, no solamente las mecánicas, que generan este tipo de complicaciones. No sé si hay alguna otra pregunta o comentario, alguien que quiera expresar su opinión al respecto. Hemos invitado a través del chat a todos ustedes para que expresen sus comentarios, hagan sus preguntas al doctor Hofmeyr acerca de estas técnicas tan extraordinarias que están realizando él y su equipo, y que para nosotros, yo creo que para la gran mayoría de nosotros, son totalmente novedosas. Bueno, si no hay más comentarios, no me queda más que, Ross, agradecerte en nombre del programa de anestesiología de la Facultad de la Facultad de Medicina y de la Universidad de Portales por tu presencia hoy día con nosotros. Ha sido realmente una exposición extremadamente valiosa de una técnica muy sofisticada para resolver estos problemas tan graves. Así es que te agradecemos mucho, Ross, por tu gentileza y la disposición de tiempo que has tenido.
Well, thank you very much, Ricardo. I've had a great privilege and pleasure to be able to interact with you and your whole team. Thank you for putting together this opportunity, and a very special thanks to the translation team who have made it effortless to interact. I hope you all have a wonderful day.
Buenas, gracias. Ross, nos faltan las preguntas post, después de la charla. Gabriela, si puedes proyectarlas para que todos ustedes las puedan ver y puedan ver si hay alguna transmisión de mensaje adecuado de la charla del doctor Hofmeyr. Dice, las estrategias de ventilación que pueden usarse para la dilatación traqueal incluyen A, la oxigenación apneica, el Thrive; B, la ventilación mecánica convencional; C, la ventilación jet de alta frecuencia; y D, todas las anteriores. Hay 2 personas que han respondido. 3. Hay algunas técnicas que ha mostrado el doctor Hofmeyr en su exposición. En la dilatación traqueal pueden utilizarse algunas de estas técnicas. Muy bien. Ahí están los resultados. Ross, mira, el 82% respondió que todas las técnicas anteriores pueden ser usadas para dilatación traqueal. ¿Tienes algún comentario?
Yeah, I think that's what I was hoping to illustrate to people, that our understanding of having to keep these patients breathing spontaneously historically has now been expanded, and actually we've got a great variety of ventilation approaches that we can use, and that really allows us to optimize the individualized management for that patient, to choose the best therapy that's going to work well for that patient, and obviously give the best conditions to our surgical teams.
Fantástico. Vamos a la segunda pregunta y la última. Esta es la segunda. Dice, es una pregunta. La dilatación con balón no oclusiva, que la vimos en la exposición, ¿puede ser usada en conjunto con qué estrategia ventilatoria? Las mismas alternativas: oxigenación apneica, ventilación mecánica convencional, ventilación jet de alta frecuencia o todas las anteriores. Recuerden el balón no oclusivo, ese balón de 8 baloncitos pequeños que dejaba espacios entre ellos. Muy sofisticado. Entonces, ¿qué estrategia ventilatoria es la que se puede usar con este tipo de balón?
Yeah, so I can see that people have been listening carefully, and actually, the answer here is also all of the above, that using a non-occlusive balloon allows us to do this with spontaneous breathing, with apneic oxygenation, with conventional ventilation, and with jet ventilation. And I was also interested to see that one of the participants posted in the chat a link to the use of the Ventrain device through the tri-tube. And obviously, being a very, very good device, not yet available here in South Africa outside of my skills laboratory. But in fact, we have used the Ventrain for oxygenation through the guide wire lumen of the non-occlusive balloon as well. So that option is also available to us, and a very, very useful and very low cost device, that Ventrain.
Fantástico, muchísimas gracias. Bueno, yo creo que ha sido una jornada extraordinaria. Muchas gracias, Ros. Ya te hemos expresado nuestros agradecimientos y creo que soy transmisor de este agradecimiento de parte de todos quienes han participado en este webinario de hoy día, y no nos queda más que nuevamente agradecerte por tu disposición y tu tiempo para dedicarnos a nosotros. Muchísimas gracias. Un gran abrazo. Momento, antes de terminar, casi se me olvida. ¿Dónde está? Acá. Nuevamente quiero invitarlos a contestar. Ay, ¿dónde estás? A contestar en la encuesta AWARE del estudio sobre intubación traqueal vigil de la EAMS. Por favor, es muy fácil, es muy cortito responderla, así que por favor los invito nuevamente para que contesten esta encuesta. Nosotros estamos en redes sociales, en Facebook, estamos en YouTube. Recuerden que esta conferencia y todas las demás pueden ser vistas por ustedes de manera diferida en nuestro canal de YouTube, canal Anestesia UDP. Pueden activarlo a través del código QR que también tienen en sus pantallas. También estamos en Instagram, en X, y les quiero dejar invitados para el próximo sábado 31 de agosto, donde la doctora Sheila Miatra de la India nos va a hablar de un tema muy, muy, muy interesante, que es la extubación de la vía aérea en riesgo, es decir, la intubación difícil. Que también forma parte del manejo de la vía aérea, porque no solamente hay que ser capaz de entrar, sino que también de salir, o en términos de la aviación, tenemos que ser capaces de despegar, pero también de aterrizar. Entonces los dejo invitados para el próximo 31 de agosto, estén atentos al link para unirse a esta nueva sesión del webinario de vía aérea de la Universidad Diego Portales. Muchísimas gracias. Un gran abrazo, que pasen un buen fin de semana. Muchas gracias. Gracias, Gabrielita. Gracias.